didactic survey if you haven't already. That'd be very appreciated. Thank you.
Alrighty, I think we could start here. So I just want to start off by thanking Seth here for coming in, spending an evening to really just go over some of the stuff that PT does in the rehab setting. We really appreciate you for coming, and feel free whenever to start.
All right. So yeah, my name's Seth Witmer, a physical therapist at the Reading Rehabilitation Hospital here in Wyomissing, Pennsylvania. Been a PT since 2014, and the last 5-6 years or so, I've been really focused on the amputee population. So I'll be giving you some information, kind of what we do exercise-wise, and some tests that we do with our amputees. First off, our goals of acute rehab are kind of starting out as an acute amputee is pain management, wound healing, and limb shaping, and then as well as strength, mobility, and their preparation for home, equipment selection, wheelchairs, walkers, transfer boards, things like that, and then pre-prosthetic training and introduction. So first off, while they're here in the rehab, any of the exercise things we're doing, we're keeping their limb wrapped, as you can see, kind of in a figure 8 pattern. And this is before the staples are removed. This is for decreasing swelling, begin shaping the limb for prosthetic training, and we keep it tighter distally to kind of push the swelling more proximal. All right, so exercise for the amputee. So we're focusing on strengthening, stretching, balance, and endurance. So the energy cost for prosthetic training is quite a bit. So for transfemoral amputees, due to non-vascular causes, it's been reported 30 to 60% greater than non-amputee control subjects. And then the energy cost at self-selected or comfortable walking speed is between 12 and 33% greater in transtibial prosthetic users than in people without amputation. So with that higher energy cost, it's really important, that these patients stay very active and continuing with their exercise program. It's takes a lot more energy costs to walk with a prosthetic than without. All right, so a MAT program. So all of our new amputees, we start them on a MAT program for exercise and strengthening. So I'll go over a few exercises that we do. So straight leg raise. So, building their hip flexor strength. It's very critical with, with weak hip flexors. It's hard to advance the prosthetic limb. First thing patients say when they get their new prosthetic is just how heavy it feels. They haven't really been using that leg for, 3-4 months. And especially with the above knee prosthetic, it really, you're really using your hip flexors, and it's a kind of heavier prosthesis. So having good, strong hip flexors to be able to advance the prosthetic leg and for to clear your foot. Quad sets. So strengthening the quads is very important. Weak quads can lead to knee buckling and ambulation. Also, we have them contract their quads with every step as they're stepping onto their prosthetic side. It kind of helps dissipate the force inside the socket to also prevent any skin issues or pain distally in the residual limb. And then also doing quad sets, we emphasize keeping their knee extended at all times to help prevent any knee flexor contracture. So, if they just kind of let their leg kind of hang down or just in a comfortable position when they're sitting or laying in bed, over time, it's going to create a really tight knee joint, and then it's really going to impact their gait mechanics once they got a prosthesis. Hip abduction. So this focuses on the glute medius muscle, which is the primary stabilizer of the hips. So as you can see there with weak hip abductors, it kind of throws off their pelvic stability. So their hip will kind of drop into a Trendelenburg gait. So with weak hip flexors, it can kind of throw off their gait mechanics and cause them to be unstable at the pelvis. So bridges and glutes. So you can do it single limb on the sound limb side or their amputee side. So strong glutes is critical for pelvic stability, balance, balance with their walking, and then it's also their primary hip extensor. And doing stairs, you're constantly extending your hips, so having good, strong glutes is important. And then this is another hip extension exercise that we have them do lying on their side. If they're able to, we also have them try to do it prone on their stomach. Prone hip flexor stretch. So lying prone is very important to help prevent hip flexor contractures. So these patients, they end up sitting, doing a lot more sitting in the wheelchair, and they can get really tight hips and tight knees. So being able to get on their stomach, even up on their elbows, 10 minutes a day or more if they can help prevent getting tight hips. Often these patients, if they end up with a hip flexor contracture, that can really throw off their gait mechanics, higher energy cost consumption trying to walk. So this is one of the important exercises we have them do. Wheelchair push-ups. Really strong triceps is very important as they're kind of going to a more wheelchair as their primary mode of mobility for a few months until they get their prosthetic. So doing wheelchair push-ups, any type of exercises that is kind of working on that type of activity. And also being able to push themselves up to clear their buttocks off their chair for offloading to prevent any skin breakdown, pressure sores of that sort. And then also just as it transitions to them being able to get up and stand. Then some other seated exercises that we often have them do, just their upper body strength ends up being really important as they're mobilizing more in the wheelchair. As an acute amputee, around their house, usually it's safer to get around in the wheelchair than trying to hop around their house. And having strong upper body is, important, being able to navigate. Some common core exercises that we'll have them do as well. So just, having a strong core is important for balance, and, as they're walking, if they have a weak core, they end up leaning more forward at a forward flex posture. So having strong core can help with their balance and gait posture as well. And then we also work on standing balance on their sound limb. Oftentimes we're starting out in the parallel bars. As they get stronger, then we'll try to progress them into the walker. Being able to stand on their sound limb is a good indicator for prosthetic training, for balance and strength and mobility. And when patients go for fitting at the prosthetist office, they have to stand and balance to get fitted. So we kind of make our goal of seeing if you can stand for 5 minutes, make that process easier in the for your fitting. The more they're able to stand as well, it helps with offloading pressure on the buttocks, then also strengthens the sound limb. And then once we get them standing, there's some exercises then we can do standing. So our hip abduction, hip extension, we can do some hip flexion here. The stronger they are, we can add weights, make it harder for them. So hopping on the sound limb, this can be a good exercise, but often it's not safe or functional. Some considerations. So A lot of our patients with amputee, they have diabetes or diabetic neuropathy. So we want to be checking their skin integrity of their foot, make sure that, there's no issues going on there. If they're not able to really clear their foot very well and they're just kind of shearing their foot on the floor as they're trying to hop along, that can kind of cause skin issues on that foot. And then there's also the condition of Charcot foot, which is the inability to sense injuries to the foot and can result in significant deformities. So we want to, not just get every patient up and try to see if you can hop. There's some considerations there on their intact limb that we want to be mindful of. Then also just their knee health and their shoulder health. If it's really a strain, especially with like heavier patients, if it's really a strain on their knee joint or their shoulder joint, try to kind of steer away and not do as much hopping. All right. So the amputee mobility predictor. So this is a test that we do. It's like a balance and gait test that kind of assesses their mobility. And so it can be done with their prosthetic when they get it, or it can be done without the prosthetic as a new amputee. So it's a 21-item objective measure to assess ambulatory potential of amputees with and without prosthesis and assess outcomes in rehabilitative settings. So it incorporates static and dynamic sitting and standing activities, as well as transfer and gait skills of progressing difficulty. So with the scoring, so it puts them into different levels, or K levels they're called. So it's K0 all the way up to K4. The higher their score, the higher their K level. And then here, we with our prosthetic trainers, we try to do this test within their first 2-3 days of admission, and then we'll do it again when they leave. Be able to kind of see their progress. The minimal detectable change is an increase in 3.4 points. Oftentimes, we're only seeing them maybe for a week or 2 weeks, so there might not be a ton of increase in the time that we see them. But later on in outpatient, they might retake this test and kind of see more of a gain. So I'll just kind of go through the different tasks that we have them do. So sitting balance, it's pretty straightforward. They just sit upright in a chair without back support. Can they sit there without losing their balance? And each one of these, there's a score 0, 1, 2. I didn't list exactly how you score all those out, just list the tasks here. But so item 2 would be sitting reach. So they have to sit there and see if they can reach straight out 12 inches. So kind of assessing their core strength and sitting balance. So chair to chair transfer. So we have them do basically just a stand pivot. They can go either to the amputated side or their non-amputated side, and they can use their hands as needed. And then we're kind of assessing which assistive device they're using. So is it walker, forearm crutches, or can they do it without any device? Item 4, arising from a chair. So first we just have them see if they can stand without using any hands. And then if they're not able to do that, they get a lower score, have them use their hands. Item 5, how many attempts does it take for them to stand up from a chair? If they couldn't stand up without their hands, then we give them another try to see if they can stand up in one try with their hands. Standing balance. So we assess their immediate standing balance. So as soon as they stand up, are they pretty steady, or does it take them a bit to try to get their balance? And then we start assessing how's their balance without holding on to any device. So we'll test it for 30 seconds. Can they hold their balance for 30 seconds? Then we do single limb standing balance. Can they stand on their intact limb for 30 seconds? Can they then try to stand on their prosthetic side for 30 seconds? Oftentimes they are needing to hold on to assisted device at this point, especially on their prosthetic limb. But the least amount of assistance they need on holding on to a device, the higher their score. Standing reach. So then we have them try to reach straight out in front of them, 12 inches. The higher the score is if they can do it without holding on to anything. If they need to hold on to the walker or so, then they get a little bit lower score. If they lose their balance and can't do it, even a lower score. Nudge test. So here I'm having them stand without holding on to anything. And then I'm basically pushing them on their sternum until their toe kind of comes up. See if they can hold their balance, or if they fall over. Obviously, having a wheelchair or chair that's sturdy behind them in case they would fall. I did kind of make the mistake one time of a bilateral below knee amputee and pushing, and basically it looked like I just like pushed them right over. So I just got to be careful and make sure it's set up safely, and also that they have no issues with me, pushing on their sternum, no pain or anything there. Then we're checking to see if they can keep their balance with their eyes closed. Again, we're testing for 30 seconds. Can they pick up an object off the floor? So I just throw my pen on the floor about 12 inches in front of their midline and see if they're able to keep their balance, reach down and pick it up. Item 13, so sitting down, see if they can sit down in a controlled manner without using their hands. Then if they have to use their hands, it'll be a lower score. And then we assess different aspects of their gait. So item 14, initiation of their gait. Do they have to kind of pause and get steady before they start walking, or as soon as I tell them to go, can they just go without any hesitation? I'm looking at their step length and height. Are they clearing their foot on every step? Are they clearing their sound limb and their prosthetic limb on every step? And then how long is their step? So are they getting a full step through about they're going to fully step past each foot. And then I'd have them walk about 12 feet distance up and back. And so I'm also looking at their continuity, step continuity. Are they kind of sort of walking with a little bit of an antalgic kind of step 2 gait? Or if they're walking with a walker, does the walker kind of stop? They walk a few steps and they push the walker again. Or are they more of a continuous kind of step through continuous gait pattern? Turning, so that I have them walk 12 feet, then turn around. Can they do it in 3 steps or less, or does it take them 4 or 5 steps? And they get scored accordingly. And then variable cadence. So can they, when I tell them to walk faster, do they walk pretty much at the same pace or at kind of an erratic, unequal gait pattern? Or can they easily increase their cadence and then go back to a regular cadence? Item 19, so stepping over an obstacle. So we put a 4-inch high box or hurdle. They walk up to it, step over it. So it kind of assesses, can they just kind of walk and easily step over a box, or do they kind of have to stop, slow down, step over? Then we have them do a set of steps. And then first of all, are they able to do the stairs? And do they need to hold on to a railing? Can they go up without any railing? Can they kind of do a step over gait? Or do they have to kind of bring both feet up on each step and then go to the next step? And then the last one is, which assistive device do they need? So, and this would be like our score. So using a walker, they get 2 points, crutches 3, cane 4. To get full score of 5 would be no device. So then once we go through all that, we add up their score. And then that'll kind of give us an idea of predict their mobility with the prosthetic. So K0 is a patient who's really not a candidate for prosthesis. They really would it not enhance their quality of life. They're pretty much wheelchair bound, and trying to use a prosthetic is not really realistic for them. K1, so this is a patient who would maybe use a prosthesis for simple transfers or ambulational and just level services at kind of a fixed cadence. So someone might use this just in the home, either in a limited or unlimited household ambulator. Oftentimes these patients might need a family member to kind of guard beside them as they're walking. They may not get to a fully independent level, but it kind of increases their quality of life. They're able to stand, they're able to walk some. And a lot of patients, they really push and want that prosthetic, even if it ends up not fully, helping them to be independent like they maybe wanted to. Then K2, this is someone who's a little bit more mobile. They have the ability to traverse low-level environmental barriers, so they may be able to do curbs, stairs, or some uneven surfaces, typical of the limited community ambulator. Then K3, so we're getting a little bit more mobile here, more of the typical community ambulator. So they're able to traverse most environmental barriers. They may have able to go back to work. They may have, be out of work for a few months and they're trying to get back to their job. Or they might be able to kind of do therapeutic or exercise activity, go to the gym, do activities that are more than just simple walking. These patients are usually able to kind of increase their cadence, quickly get across the street, navigate around in the mall or go to sporting events, those kind of things. And then K4, that's kind of your highest level. So your athletes, they're doing, very active sports. Oftentimes you're the child who's been a, amputee since birth. They've really been used to it and they can be much more active, hiking, climbing, things like that. And so one thing of this amputee mobility predictor that can impact the type of prosthesis that you get, type of technology that's out there. So it can change as they progress and accept new challenges. And an increased K level may qualify a person for more advanced prosthetic components. So the different components of the prosthesis is the socket, so what the residual limb is sitting in. And then for an above knee prosthetic, you have the knee component. So there's a couple of different examples of knee components. So for a K1, it's just a single axle, has like a manual lock. So basically just they walk with just the knee completely locked. A K1 can have the opportunity of, as they progress, you can unlock it, but it's just basically just a single axle and they're just kind of swinging the leg forward. And but as you progress K2, it's multi-axial, so it might be just completely unlocked. So they're walking, they're able to just kind of swing the knee, the pylon forward, and as they stand on it, there's friction. So with weight on it, it kind of locks so that it doesn't buckle. K3, then you have your microprocessor. So that's a little bit more complicated. Basically, there's a computer component in the knee, and it kind of does some automatic movements as you walk, and it those are pretty neat to work with. Yeah, microprocessor needs, is some studies out there that they're actually safer than the other knees, because as you stand on them, it kind of knows, the computer knows to not buckle. But unfortunately, they do cost a lot. Insurance often doesn't. A lot of our VA patients have the microprocessor that, the VA pays for it. So the other components, you have the pylon and then the foot. So you can get a little bit more complex foot component the higher K level that you are. And I just gave some examples there. As you go along, there's more advanced types of prosthetic feet out there. All right. So that's all I have for you. If there's any questions or anything about any of that.
Thank you very much, Seth. I just
Yeah.
had a quick question. Do you typically see like a big jump in K levels like in patients that you see, or do you think they just go up like one level at a time?
So I'm more in the acute rehab side of things.
Mhm.
So in the time that I'm seeing them, they're kind of at that level.
Okay.
But I think more realistically, it's probably kind of like one jump,
Mm.
maybe a K2 to a K3 is probably what we're seeing the most.
Mhm.
Where they might be maybe starting out, just maybe able to start doing some curb steps, a little bit of uneven surface. And then as they get along and they are able to progress down to like just a cane or no device, able to maybe get back to like hiking or fishing or doing some of those little bit more advanced things. And then maybe they need a different prosthetic foot that kind of has the ability to kind of handle those uneven surfaces or hills or whatnot. So yeah, that's kind of what I would say, maybe one level or so.
Gotcha. Thank you. Any more questions? Alrighty, Seth, thank you so much again for coming in and talking
Yeah,
about that. That was actually very helpful.
yeah, thank you.
Thank you. Alrighty, next up we have Meredith here. Thank you again for joining us and spending the evening with us a little bit.
Yeah, no problem. Thanks for having me.
Yeah.
I'm gonna get my PowerPoint up here.
Oh, I'll stop sharing. There.
Let me see. Okay, can everybody see it?
Yep.
Okay. So my name is Meredith. I am an occupational therapist. I work with Seth. We work at Reading Rehab Hospital in Wyomissing, part of Tower Health. Seth kind of is, we kind of work on different spectrums. Seth works with our amputee patients, and I mostly work with our neuro patients. So I mostly work with mixed neuro, Parkinson's, MS, spinal cord, especially stroke and spinal cord, and brain injury, excuse me. So just to give you a little background, if you're not familiar with occupational therapy, as Seth said, he is a physical therapist. OT and PT work very, very well together in the acute rehab setting. But this is just a quote from our American Occupational Therapy Association. So OT allows people across the lifespans to do activities they want and need to do. An occupational therapist will evaluate your situation and with input from the patient, develop individualized goals that allow you to resume or pursue your valued occupations. After you develop goals with your OT, you will work together on an intervention plan to help improve and maintain your ability to perform those activities. So just a background on OTs, they have a graduate level degree in occupational therapy, but a lot of the undergraduate degrees are in kinesiology, exercise science, health science, psychology. And then we currently are at a master's level education, but we are moving to a doctorate to kind of be synonymous with PT. So OT's role in inpatient rehab, we work on a lot of different things. Primarily, our biggest focus is on what we call activities of daily living. So that's bathing, dressing, toileting, grooming, all of those self-care activities. We also work with what we call instrumental activities of daily living, or these IADLs, and that is anything kind of around the home. So home management, laundry, finances, medication management, driving, grocery shopping, things like that. We also, depending on the diagnosis, we work on neuromuscular reeducation, cognition, vision. We work on just general strength, balance, coordination, endurance, transfers and mobility. We kind of just work alongside kind of implementing some of the strategies that PT initiates with the transfers and mobility. They are obviously a little bit more trained in those aspects. That's their kind of their specifics is gait and ambulation. So just a day in the life of an OT in acute rehab. We have at least 1 or 2 ADL sessions a day, give or take. You know, we could have a few more depending on just how we have it set up. So I work 7 to 3:30. Our first ADL is at 7, so that's a full shower session. So you're doing a shower, getting them, you know, washed, dressed, working on all those self-care tasks, working on toileting during that session as well. And then throughout the course of the day, you have anywhere from 4 to 6 treatments. So like I said, some of those will be just straight what we call ADL sessions, which are just kind of the bathing, the dressing, toileting. And then the other sessions, we may be working on other things. We do get some non-productive time, so doc time. And then we have stand up 3 times a week. So that's where we'll meet with the care team. And that is just a brief 15-minute meeting with the care team. So that's the physiatrist, any residents that we have as well, PT, OT, speech if they're involved, the case manager, nursing. And then 1 time a week, we meet for an hour-long meeting to go over kind of all of the patients more in depth. And again, all those same individuals are included in that meeting as well. So just including the team, that kind of what I talked about, it's either the physiatrist, the nurse, PT, OT, speech, the case manager, who's typically social work or nursing background, neuropsychology, and then also PCAs, so kind of our nursing aides. So we are an inpatient rehab facility. We have, I think it's 65 beds total. Inpatient, we have 50 just kind of regular rehab beds, and then we have 11 or 15. I forget how many we have. We also have a locked TBI unit, so we have 11 beds up there. So the inpatient rehab guidelines, we have to have, the patients have to have at least 3 hours of therapy 5 out of the 7 days a week. And that has to be within at least 2 disciplines. We do try and give patients at least 6 days of full therapy. That's just dependent on staffing and things like that. But they have to at least get 5 days a week of 3 hours to meet compliance. So when the patient first comes in, we are responsible for capturing admission scores within their first 3 days. And then we also are responsible for capturing discharge scores within their last 3 days of their stay. So when a patient comes in, we are OT is responsible for assessing feeding, oral care, bathing, upper and lower body dressing, donning and doffing footwear, toileting, and toilet transfer. PT works on capturing all of the additional transfers like sit to stand, any wheelchair mobility, ambulation, stairs. They capture all of those admission scores. So when a patient gets admitted, the first day that they come, that is day 1. We do not see them that day. We see them day 2. So we have day 2 and 3 to capture these admission scores. Because typically day 1, when they're admitted, they're coming in late in the afternoon. The physiatrist needs to go in, do their initial assessment. Nursing has to do their initial assessment, you know, gather their H&P and so forth. So this is just a quick reference for the GG scores. We go off a functional level to determine GG scores. So it ranges anywhere from independent to dependent. So obviously dependent means that the patient needs total assistance, whether that's a total assistance of 1 or 2 people or even more. So that would be a score of a 1. A 2 is a substantial or maximal assistance. So that's when the patient needs more than half, but not total assistance. So that's anywhere from like 51% to 99% of whatever task they're doing. And then partial moderate assistance is anywhere from like 25 to 50%. And then you have supervision and touching assistance. So that's supervision is that you're just giving the patient cueing. Touching assistance is you're just steadying them, kind of giving them what we call contact guard. You're not giving them any actual physical assistance, just kind of steadying. And then we have setup, which is just basically setting them up for the activity, whether that's like handing their shirt to them. And then obviously independent is they are able to retrieve anything like the item themselves, put it on, and so forth. So when a patient first comes in, we assess all of those areas I said before. So bathing, dressing, toileting, we give them an admission score based on the GG scores here. And then before they leave, we also assess them and give them discharge scores. And that is how we measure their progress within their stay. So just to kind of give you a background on OT within acute rehab, I am just going to give you a case study on one of my patients. It was a really good case from a lot of different aspects, not just physical and kind of what was going on medically, but also she had a lot of kind of social issues as well. So this was a patient. This was their brief H&P from the physiatrist. So she had an intracranial hemorrhage, pretty massive hemorrhage. She did have a craniotomy. This was just on her exam. She was not cooperative, crying and trying to get the mitt off her left hand. So she did have a restraint on. She was a dense right hemiplegic. So we didn't have to mitt her right hand because she had no functional use of it. We had to mitt her left hand because she did have a trach and a feeding tube. So we wanted to make sure that those stayed intact. 70-year-old female. This is just kind of her brief history. She came to the hospital with right-sided weakness, confusion, dysarthria. She came in hypertensive. She had, like I said, a intracranial hemorrhage. And this is just kind of, you can kind of just, I'm not going to read it word for word. She did have vent-dependent respiratory failure, so they did place a peg and a trach. Like I said, she did come over to us still with the peg and the trach. Sometimes patients will get them, will get decannulated. The peg usually has to stand 6 weeks after it gets placed. So usually if they do get a peg placed in-house, they're usually coming to us with it. So just to kind of go off of her, this is just her previous medical history and surgical history. Nothing really too crazy, just some, hypertension, elevated cholesterol, things like that. So this is her imaging. You can very clearly see the hemorrhage, pretty mass effect. This is just her evaluation, her therapy evaluation from me. So when we go and do our initial eval, some of the stuff within our eval is just drop down. So all of the impairments, it's just a check off list. You just check off anyone that applies to her. We put in all of the precautions. One of the biggest things within inpatient rehab is they want you to ask the patient each session or at the beginning of their stay, especially, what is your goal? She was non-communicative. She was very aphasic globally, so she could not express her speech or comprehend as well. So this trach handoff is just something we do as a facility. You have to meet with the nurse at the beginning of the session to go over the parameters for her trach collar. So one of the biggest things that OT does within the evaluation is we gather an occupational profile. So we look at her prior level of function, her living situation. She was a bus driver. She lived with her husband and her son who had a developmental delay. Her husband, she was a caretaker for, not physically, but he could no longer work. He had a lot of heart conditions. But you can kind of see they're having a classic 2-level colonial house. Her bedroom and full bathroom were on the second floor. when she came to us, she was not following any commands, very dense hemiplegic, could not move the right side at all. Even moving her unaffected side purposefully was, she could do it kind of spontaneously, but following commands was really hard for her just because of the global aphasia. So like I said, this just kind of goes over her prior level of function. She was independent for all of her ADLs, so that's all of her self-care tasks. She was doing all of the IDLs around the house, taking care of her medications. She was employed full-time as a bus driver. So this was her current level of function on eval. She was assist of 1 to 2 for each aspect. She was obviously a total feed for feeding. She was on a feeding tube. She had the peg tube. She was NPO. They weren't even allowing her to trial things PO at this point. We had to do a bed level ADL because of her trach collar. You can shower with a trach. Typically, the patients who come in with a trach the first day, it is very difficult to get everything assessed and through a full shower. A lot of times when patients come in with a trach, we try capping trials pretty fast if it's appropriate and if it is recommended by ENT or trauma. So we usually try and have them capped before we shower them, just because obviously if water's getting in there, you know, could be pneumonia, things like that. We do have trach covers, but we just try and kind of capture the admission scores. So she honestly was not really appropriate for a shower safety-wise the first day. So we did everything bed level, and she needed assist of 1 to 2 bed level. And she was pretty tiny, but she was just so impaired. So this just kind of goes, again, she needed assist of 2 for everything. In terms of her balance, even we did get her edge of bed. Her sitting balance was very, very poor. Obviously her standing balance is poor as well. Her right side was affected. There was no not even trace movement with anything. Sensation did appear intact. There were clear visual deficits as well. She did have a gaze preference. Demonstrated some motor apraxia. So this is just kind of a brief synopsis of my eval. Just overall very, very impaired. And also her cog and language deficits really impacted her as well, not just her hemiplegia. So just some important aspects of this eval. We had this obviously a trach patient. You have the trach here and the trach collar. With a trach patient, they're always going to be on continuous pulse ox, just so you're monitoring their heart rate and oxygen. And then she also obviously had a mitt that I talked about earlier. With the mitt, we do trial taking the mitt off within sessions, and we will document if there's any intention for the patient reaching towards the trach to try and pull it out, or reaching towards the peg. We'll trial, like I said, we'll trial off in sessions. So then we can tell the physiatrist, hey, I think we can maybe trial the mitt off with direct supervision with nursing. They didn't demonstrate any, any intention to pull at any of their tubes or anything like that, because the goal is to get them off of the restraints. So this is just some of the client factors that we look at, especially with this patient. So the mental functions, attention, memory, thought, emotions, sensory functions, neuromuscular, joint mobility and stability. She had a lot of tone, increased tone in her affected side. So almost immediately we started some splinting. So overnight we had her in a resting hand splint to keep her hand in kind of a functional position. And then we also were using an elbow extension splint, 2 hours on, 2 hours off, because she was getting that flexor synergy pattern. So establishing goals, we pretty much make goals for all of the ADL aspects. So toileting, bathing, dressing, showering, toilet transfer, shower transfer, tub transfer if they have a tub shower. For someone like her, excuse me, we also would make very just basic general goals, because she is someone that's not going to initially make a ton of progress in terms of function. It's going to take a little bit longer. So some of our goals will be that she will follow 25% of ADL related commands. She will attempt to wash 25% of her face. She will wash 2 out of so many body parts, things like that. So we'll do short-term and long-term goals. Short-term goals are looked at each week during a weekly assessment. We do a weekly note. We address those short-term goals, and then the long-term goals are obviously addressed throughout this day, and then we'll document on those in their discharge note. So it's incredibly important to prioritize an acute rehab, because back in the day, you used to get weeks upon weeks in acute rehab, and that's just not the case anymore, unfortunately. So we look at, what does the patient need to be able to do in order to go home safely? Our goal is to get the patient home first. If that is not feasible, then to the next care setting, whether that be a subacute, a long-term care, or anything along those lines. And what deficits are time sensitive? So I kind of talked about earlier, this patient had a ton of tone in her upper extremity, so we wanted to get splinting done right away, and just with neuromuscular reeducation, repetition is key. So really getting that repetition in and really maximizing their therapy, because when they're in acute rehab, that's the most amount and the most intense therapy you're going to get outside of like an acute care hospital. So when they go into the acute care hospital, they're going to get medically stable. They will assess the patient to see what kind of level of care they're appropriate for, and if they believe that they will be able to tolerate the 3-hour rules, then they'll send us to acute rehab, and that is the most amount of therapy you'll get and the most intense. So it's really important to maximize their therapy while they're with you. So we work on ADL independence, so getting them more functional within their own self-care tasks. And then if it's appropriate and they're cognitively able, working on medication management, maybe some return to driving tasks. I am not a certified driving rehab specialist, but we do some pre-on-the-road testing. So we'll look at visual functioning, cognitive functioning, just some other trail making tests, things like that, to see if they're even appropriate to kind of sit in our driving simulator with our kind of our driving specialist from our outpatient. If the driver specialist and outpatient thinks that they are appropriate for an on-the-road assessment, then they will refer them to a certified driving rehab specialist. But we also are going to work on, obviously, us getting their ADL independence is super important, but we need to work on some of the baseline things, the foundational skills, such as sitting balance, standing balance, use of their affected upper extremity. We kind of balance that compensatory versus remedial approach, and then vision, things like that. So these are some of our outcome measures and evaluation tools. The first one is box and blocks. So this gentleman at the bottom here, this is kind of a gross motor and fine motor coordination test. You time the patient for 1 minute, and they're going to do it once with each hand. So for 1 minute, they're going to take their left hand and pick up 1 block at a time and move it over the divider as fast as they can. We'll see how many blocks they get, and then they're going to do the same thing with their right. They're going to pick up 1 at a time. So we'll typically try and get these outcome measure scores within the first couple days of their stay, and then we will do it at the end of their stay as well. And that's another way that we can kind of show progress while they're in rehab. The 9-hole peg test up here at the top, that is more of a fine motor coordination indicator. We also use the dynamometer, which is a grip strength test that measures in pounds per square inch. In terms of vision, we use the BIVABA, which is the brain injury visual battery assessment. And then the MOCA is something we use for cognition. Now, speech also works a lot on the patient's cognition, but they may not get consulted right away. So we may just do a quick MOCA, which is the Montreal Cognitive Assessment. And that looks at visual attention, abstract thinking, visual spatial, executive functioning, recall, and it's a quick 20-25 minute test depending on the patient, and it'll give you a score out of 30. And it'll rate the cognitive deficits as mild, moderate, or severe, depending on the score. So within this patient that we're kind of doing the case study on, this was just some equipment that was utilized throughout her stay. So this top left corner, this was called a shower buddy or a tilt and space shower chair. We had to use this for her when she first started bathing because her truncal control was so poor that we needed to be able to strap her in and also tilt her back so that if she was sitting up, she wasn't leaning side to side and basically falling out of the chair. This also provides us with a commode, so we could also do toileting and bathing kind of in one. As she progressed, we then moved on to toileting with a bedside commode or a regular toilet. We try and get them on the toilet as much as possible, but sometimes with nursing, it's just easier to use a bedside commode next to the bed. Top right, this is a tilt and space wheelchair. Again, her truncal control was so poor when she first came. She needed the tilt function because if she was sitting fully upright in this standard wheelchair, like down here in the middle, she would have fallen forwards and out of her chair. As she progressed, now this patient did make a ton of progress. She ended up leaving the facility in an ambulatory status. We started with a quad cane and then worked our way to a single point cane. Some technology that we use for most of our neuro patients. Top left, we have the BERT, which is the bionic upper extremity robot. In the middle here is what we call the Dynavision. So it's a light board and you can set certain quadrants up. So if they have a visual field deficit, you can only light up the side of the board that you want them to attend to. Over here on the right, this is a standing frame. So for patients who like this patient, when she first came, she was so just so fatigued and could not even really tolerate, her activity tolerance was really poor, activity endurance. So we just worked on standing in the standing frame with her because her balance was so poor too. So we got her in the standing frame. We cranked it up so that she was standing. We were kind of behind her, holding her trunk up. We had a mirror in front of her, working on her midline positioning because she was leaning so far because her midline orientation was off. Also using the 0G system down here on the left, which is an overhead harness system. It's a body weight support system, so you can offload some of their body weight, and it allows you to kind of facilitate the patient a little bit better because you're not worried about you holding them up and also facilitating. The machine will help hold them up, and it gives really good feedback to the patient as well. And then in the middle down here, this is the Bionus upper extremity device. It's an electrical stimulation that works on functional grasp and release. This is just some ADL equipment that we use with patients. Sometimes it's necessary for patients, sometimes it's not. But this is a reacher up here at the top left, long-handled shoehorn, foot funnel to help get your shoes on, a long-handled comb, sock aid, this helps get your socks on, long-handled sponge, button hook, toilet tongs if you're having trouble with toileting hygiene. So within OT and acute rehab, again, we really have to prioritize what do we need to be able to do to get them home. Do they need any type of equipment? A wheelchair, a cane, a tub transfer bench, or a shower chair, anything like that. Is there any family training that needs to be done? Is the patient not going to be independent? Will they need to rely on family to help them? If that's the case, then the family needs to come in, do family training with the therapist so that we know that they're going home at a safe and optimal level. And then just in general, what's their discharge disposition and setup? Is a home eval necessary? And then follow-up services and community resources. So we do a lot of support groups within the rehab. We are CARF certified for amputee, brain injury, spinal cord, and stroke. So we have all of those support groups in the community. In terms of follow-up services, are we recommending outpatient or home health? Now, within this patient, I kind of touched on this before, she had a lot of psychosocial factors as well. Her husband was pretty critically ill by the time she was in the hospital and actually passed away. He was awaiting, I think, a heart transplant or something along those lines. So that was a big part of her stay as well. We actually had to do family training with the family so that she was able to attend her husband's funeral and then come back to us to finish her rehab stay. So it's not always just cut and dry. There's a lot of other aspects kind of going on as well. So at discharge, this patient, who was assist of 1 to 2, went home a supervision level or contact guard. So she just needed steadying assistance when she was up or supervision. So just giving her verbal cues like put your hand here when you're transferring into the shower, things like that. Didn't really need physical assistance, she was an incredible case. And like I said, she couldn't even sit up when she first came to us. And then I think it was within 5 or 6 weeks, walking with a single point cane, doing very, very well. So this is just something her speech came a really long way too. She was then able to start verbalizing with us. Her command following obviously got much, much better. But yeah, she was what we call a success story. So I just kind of use the case study to kind of go over OT in general within acute rehab. We work very, very closely with PT, speech, the physiatrist, nursing as well. So we really, really take an interdisciplinary approach. Does anybody have any questions?
Thank you so much for presenting. I just have a quick question about like the ADLs and IADLs that you typically see.
Yep.
So in the neuro rehab setting, do you find patients having difficulty with a certain like mobility, like transferring or like going using the toilet or showering? Like, is there like I guess not like a common presentation that they usually have issues with?
Yeah, toileting is always a big one,
Mm.
especially with the neuro populations, especially with like spinal cords, establishing like a bowel routine, so we work with nursing and the physiatrist to determine what is a good time frame for a bowel routine. Typically after a meal is great because we know peristalsis of the stomach, that helps kind of move things down. But toileting is a really big one that is difficult at times because we kind of see toileting as something you have to do. You have to be able to, you have to be able to pee and poop. When you go home, you have to be able to manage that. So it's one thing if you're not fully independent with showering, that's okay because usually you'll have family home with you that can help you with that. But let's say your family works during the day. You can schedule your showers around when your family's home at night, but you can't really schedule when you're gonna have to use the restroom.
Right.
So kind of getting on like a toileting schedule or working with the family and maybe let's say like limiting liquids after a certain time because overnight is a big thing too, just because if a patient can't ambulate or pivot or stand pivot onto a commode at night, they're gonna have to rely on their family to get them up with them to safely take them to the bathroom. So trying to get them on just kind of a bowel schedule or avoiding schedule in general,
Gotcha.
so that it kind of decreases caregiver burden, but also gives them a little bit more of independence. So sometimes we see patients who their family toilets them before they leave, and then what we do is we'll say, have your family set you up with some snacks and things. And if they're only gone for a couple hours, that's great. Usually they can hold it or whatever. So, but if not, then, that's one of the barriers to home. But I would say toileting for sure.
Mhm. Yeah, thank you so much.
Yeah, of
If
course.
anyone else has any questions. Alrighty. Thank you so much again for helping us with the presentations and
Yeah, of course.
just
Thanks
giving
for
us
having
insight
us.
into that. Yeah, thank you so much.
All right.
All right, bye.
Take care.